I grew up in Germany, close to the Bavarian Alps. I was never going to be a doctor because both of my parents are. I was going to be a pizza maker, then a pilot, and then I ran out of P letters other than physician. So that's what happened.
I'm much more simple than you. Toronto born and bred. I grew up in Downsview, Ontario, the son of two immigrant parents. My story is very unusual. I became a professor of emergency medicine at U of T without a master's, without a PhD, but pure persistence and dogged determination.
So if I wasn't a doctor, I would just be a semi-professional surfer. I would spend my time in the water and just experience that nature.
If I hadn't discovered medicine, where would I be? I love sports. Hopefully I would be a professional golfer because I play a lot of golf.
It's a really good restoration. If you work a job like we do, you really need something to balance that out. So the reason we work really well as a team, I think we're very much united on our vision, but we have really complementing strengths.
I'm the yin to his yang. This ability to bring my experience, my scientific background with Johannes's brilliance of an idea, his meticulousness of how we're going to move it forward, it's really a great combination.
As a level 1 trauma center, St. Michael's Hospital provides excellence in trauma care to a large geographical area. We've built up an expertise that doesn't exist anywhere else. When somebody suffers from severe injuries, every minute matters. We know that the care that we provide in the first 60 minutes after injury can make a difference between life and death, between disability and recovery. And this is where this idea of a critical care response unit, or a CCRU, was born. Instead of waiting for the patient to be brought to the emergency department, can we bring emergency department care to the patients?
Canada, from a geography point of view, is perfect for a CCRU. We have so many rural areas that are difficult to get through. So what better thing to do than pioneer this concept and change the vision of trauma care across Canada?
We can be the first in North America to get to this level, and we can make the mold for excellence and set that standard.
For Johannes and I, tonight is our World Series.
This man, 120% passion. We're going to talk about something else we're both passionate about. We're going to talk about trauma care.
Let's do it. You may be surprised to know that trauma is the main cause of death for Canadians under the age of 45. And the reason really is quite simple. When you suffer major trauma, it's a race against time, where every minute matters.
This, unfortunately, is a true story. I still remember the day that this patient arrived in the emergency department. By the time she got to us, she had lost so much blood that we were not able to save her life. And I remember thinking to myself, if only we could have reached her 10, 20, 30 minutes earlier, we would have had a real chance to stop that bleeding and to save this person's life. Because here at St. Michael's Hospital, we have one of the highest trauma survival rates in all of North America. If you or your loved one gets injured, we have the equipment, the expertise, the innovation to save your life. But you do need to get to us first.
I can train the greatest paramedics in the world. They get called to the scene of a trauma, they stabilize the patient, and then they begin the race to a trauma center. The reality in Toronto is this: you cannot get to a major trauma center within the time frame to make a difference for our patients.
So what we're proposing is this: when every minute matters, instead of waiting for patients to be brought to the emergency department, let's bring emergency department care to the patients when they need it the most. And that is the concept behind the Critical Care Response Unit, or CCRU. A team of doctors and paramedics working together to deliver the highest level of pre-hospital trauma care in all of North America, right here on the streets of Toronto.
The current paradigm is quite simple. We send ambulances to trauma patients. They can perform limited interventions, and then they drive as fast as they can to a trauma center. The new paradigm, though, will dispatch an ambulance plus our critical care response unit together, providing life-saving interventions that could only be done in the emergency department right on the scene. We then transport a stable patient to the trauma center.
So what are these interventions that we're talking about? In short, it is everything that we can currently do in the trauma bay at St. Michael's Hospital. Importantly, all the equipment required for these interventions would fit into the back of a modified SUV, such as this one. With the CCRU, I can use ultrasound to diagnose internal injuries. We can replace precious lost blood through blood transfusion. We can use innovative technology to stop internal bleeding that's currently way out of our reach. We can protect you from secondary brain injury by providing a general anesthesia. I can even do focused open heart surgery. Right there and then, a CCRU can save your life.
A critical care response unit will be made of an emergency doctor and specially trained paramedics working collaboratively to give the best care for trauma anywhere in the world. Within 24 months, we will design, implement, and evaluate the efficacy of our critical care response unit and test it, comparing it to what we've seen previously over time.
I know that trauma can happen to anybody at any time. And when it happens, people put their trust in us and into the healthcare system to do the best that we can. So to us, a CCRU is more than a healthcare innovation. It is a promise to be there when you need us, to go the extra mile.
With Angel's Den funding, we want to change the narrative of life-threatening trauma from death and despair to survival and recovery. Because to survive major trauma, every minute matters.
Thank you.
Listen, I've always had tremendous empathy in traffic with the guys or girls driving those ambulances, trying to navigate and having people tough to move out of the way. So I don't think there's any question that we have a big issue and it's a big problem. Correct me if I'm wrong on this misconception, if this is a misconception. Do we not have a shortage, though, of doctors and surgeons and people available, right? If so, how do we make it work logistically when we're asking the same people to go out and also be in attendance? How does that work from a numbers perspective?
Yeah, I think that's a question that frequently comes up because that's what's in the news and in the media. So I'm an emergency physician, and we all love what we do as emergency physicians, but we all need to do something else. Our problem is less recruitment, it is about retention. It's doing this job for 30, 40 years. So every one of my colleagues, including me, has something else other than emergency medicine. We do addictions medicine, we do cosmetic surgery, we do pre-hospital care, we do logistics. So this is actually something that can increase our longevity in our career, having a second leg.
Sorry, so the variety that this affords, you're suggesting is going to, take away from some of the extracurricular like the surfing, for example.
Thank you for answering that question much better than I did, yes.
Hard to believe on that one.
It seems when I look at it, tell me why we wouldn't take the expertise of the critical unit and put it in the ambulance. Could we combine the two? Why are they two separate vehicles arriving on the scene?
So the reason for that is you'll need a team to actually treat that patient there, but you'll also need someone to take the patient from the scene back to the trauma center, and that will usually require more than just two people. You've got trauma, you've got people doing interventions on the scene. Yep. Those people aren't driving the ambulance back as well. Okay. With these types of traumas, the more people you have on deck, the more you need. So 2 people in a major life-threatening trauma is simply not enough. So I think you need both of them to make a difference. Yep.
Yeah, and if I may add to it, this is an addition to the current EMS system. Yes. So it's adding on, working together, not replacing.
I'm curious to learn more about the geography, I guess. Do you envision the CCRUs being dispersed throughout a city like Toronto at maybe some of the bottleneck areas? Do you see it extending out into more rural communities? And then is that kind of what the next 24 months look like, is mapping out where the best locations are to dispatch from?
Yeah, so we've done research on this, and we know from the research geospatially, there are specific areas that could make a big difference in terms of response times and in terms of how close are you to a major trauma center. So with this pilot, we want to look at areas that are clearly impacted by this. So you look at Peel region, that's a perfect spot for this. When we show that that concept works there, using it in other areas that we've already determined through our mapping will be a very simple process. But we've got to start somewhere, and I think this is a place to start.
Can you walk through what you'll do with the money, what sort of the staging out of the support that you're looking for?
Sure.
Yeah, so there's some very important distinction here, is that we want to do something that doesn't exist yet in North America. Right. So that is the big project. But we don't just want to do it, we want to create the data and the evidence that allows it to grow and continue. And that's where angel stand funding comes in. It allows us to put this whole thing onto a scientific, sound foundation for continuous growth over the coming years.
Is this all going to be cool with the paramedics? that to have the top dogs riding shotgun?
So you know what? That's an excellent question. And actually, although it's humorous, it's actually an excellent question. Most paramedics will be quite ambivalent about this because paramedics in general don't want doctors riding in the ambulance. This is their environment. But this is an opportunity to do something never done in North America before. Uptraining paramedics to learn to do some of the procedures that our emergency physicians are only doing in the emergency department right now. The future may be only paramedics in the truck, and then you get around that question you asked earlier about the supply physicians.
Continuous learning opportunity.
Exactly.
Yeah.
So we can
That's
train
cool.
them to actually do this. So I think that's the carrot at the end of the road for the paramedics.
Interesting.
It's shocking it doesn't exist anywhere. Is there a model are you modeling
There sort of
after
is
somewhere
one in
else?
Israel, right?
Yeah.
Which is slightly different, but there's a sort of a crowd-sourced emergency response in Israel that kind of feels a little bit, and it works very well. Not at this level of tech expertise, I guess.
So, go ahead.
I mean, so as a natural pessimist, the reason I'm so optimistic about this is because I've seen it work over and over and actually done the job when I worked in the UK, where so we also don't have to invent this from the ground up.
Right.
There's a successful model, so we have a blueprint that we can work towards too.
One quick question, I guess, is it software? What actually alerts you that this is the right scene for this expertise? Because that will be critical, that you don't send people to places where they're not needed.
Yeah. So I think that's going to be a dispatch issue, and that's going to be something where we're going to have to work with dispatch to ensure that we're going to the right patients.
Yeah.
And sometimes that's very difficult, and certainly there is a potential that you may go to some patients where you're not needed. But that's the issue. You want to actually send out the umbrella to as many because you're going to catch the ones that you just don't want to miss. So I think that's going to get better over time, but hopefully we get the chance to do it.
Well, let AI do it.
Thank you.
Thanks, guys.
Go Jays.
Yeah, go Jays.